Hey everyone, I'm back and I'm here with Creepy Andy, who's going to help me out and help me demonstrate blood pressure in a little bit. Don't let him freak you out. He's just here to help. Okay, so far we've talked about the vascular system and mostly the mechanical makeup of the vascular system and to some degree how it uses dilation or constriction in order to maintain homeostasis of circulation. We also have ways of measuring circulation, or more precisely, measuring perfusion. In medical terms, perfusion means the adequate delivery of blood to all your tissues and organs. So we might say be measuring perfusion in a hand to see if that hand is getting adequate blood flow. We might measure perfusion in an organ, etc. But what we basically mean is, are you getting enough blood to deliver oxygen, to take away waste, all the things we've talked about in previous videos. That's basic perfusion. One of the ways we measure the overall wellness of the circulatory system is with blood pressure. And you're probably aware of this because probably at least several times in your life you've gone to see a doctor and the first thing they did was take your blood pressure. And throughout your life, probably every time you go see a doctor, they're going to be checking your blood pressure. There's a few reasons for this. One is it's a pretty good indicator of the wellness and health of your circulatory system and your heart in general, and it's a quick check. And the other is that it's a good warning sign. That is to say, if your blood pressure's high, and even if your blood pressure's abnormally low, that could be an indication of something that's really significant. So basically, whenever we're providing care for a patient, one of the things we're going to check right off the bat is blood pressure. Now, when I say blood pressure, I don't mean blood pressure throughout the circulatory system, right? We've already talked about that. You can imagine that the pressure in the arteries is very different than the pressure in the capillary beds, and that's really different than the pressure in the veins. In fact, the pressure in the veins is so low, as you'll remember, that we need special valves and to rely on passive constriction to allow the blood to work its way back up to that collecting chamber, that vena cava, that's going to deliver it back to the heart. By the time it gets in the vena cava, the pressure in that system is very low. So when we say blood pressure, we really mean the delivery of blood pressure just after the heart. So one way of imagining that is with this graph that I drew out here. Now, you don't need to worry about the graph too much, but if it helps you, great. Basically, in the aorta and in the arteries, your blood pressure is going to fluctuate. The reason for that is when the blood gets pumped by the heart, that creates a high pressure. And then in between the beats, you have a lower pressure. The heart is actually only beating about a third of the time. And then the other 2/3 of the time, you're between beats. Lub-dub, 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 lub-dub. You get the idea. Do you like the sound effects? Yeah, I've been practicing that. Okay. Anyways, so what we get then is a fluctuation. The pressure goes up, comes down, goes up, comes down in the aorta, in the arteries, to some degree in the arterioles, though then the fluctuation decreases some. And then when you get to the capillary beds, it starts going way down. And when you get into the venous system, pressure's very low, right? And then by the time you get to the vena cava, the pressure has gone extremely low. So this is the pressure we're interested in. That's the delivery pressure. That's going to tell us how well the heart is functioning, and it's going to identify some red flags for us if that pressure is high, because a high pressure could do damage to your circulatory system. We'll talk about that later. But for now, you should understand how we measure blood pressure. We measure it in millimeters of mercury. That may seem like a weird number, but it's one we defined a long time ago and now we're stuck with it. The way to understand it, if you want to wrap your head around why we're measuring in millimeters of mercury, is imagine we have a glass tube, a vertical glass tube, and we fill it with mercury. Mercury is sort of a viscous, a thick silver liquid. So we put this thick liquid in there. It's silver, so we can see it. You could imagine that if you hooked up a hose to the bottom of that and blew in, the harder you blow, the higher the mercury goes. And if you blow really hard, you're creating a lot of pressure, and the mercury goes up. That would be measuring your pressure in millimeters of mercury that you can make the mercury column rise. That's basically, more or less, how we're measuring blood pressure. Not really, but that'll give you some sense of the scale. Does that really matter? Not a hell of a lot. Here's what matters. Normal blood pressure is considered to be about 120 millimeters of mercury when your heart is in the middle of a beat, and about 80 millimeters of mercury when your heart is resting between beats. And we express that as 120 over 80. The 120 number is called systolic, and the 80 number is called diastolic. So the systolic number is the number when your heart is in a beat, and the diastolic number is your your vascular pressure between beats. If you have trouble remembering that, remember that diastolic begins with D, and that is also down. That is, that's when your pressure is down, and that's the down number. So again, we express it as 120 over 80. So the down number is the diastolic number, and that is when your pressure is down. 120 over 80 is ideal, or at least it's generally pretty ideal. Varying from that a little bit is no big deal, but once we vary from that more than a little bit, then we get into some troubles. So before we get into that part, let's talk about how we measure blood pressure. We use this, which typically is called a blood pressure cuff, and that's a perfectly good name for it. The technical name is a sphygmomanometer. You don't need to memorize that, but if you want to sound like a smarty pants in a hospital, you could refer to their nice sphygmomanometer, and I would guess that the nurse would look at you like, what the hell are you talking about? Okay, here's what we're going to do. We have a little bowl. We're going to squeeze air into that cuff until we cut off Andy's blood flow, both his arterial flow and his venous return. And then I'm going to use my stethoscope, and I'm going to listen for a heart sound in Andy's arm. Andy's very cooperative. He's just going to sit there. Now remember, I've created a high pressure. I'm going to look at this dial, and I'm going to release the pressure slowly. And as I release the pressure, what will happen is that once the pressure is below the arterial pressure, I'll start to hear a beat in his arm, because once the pressure is lower than the arterial pressure, arterial blood is going to make its way through. But I will hear that beat because that blood is still going to be going against a back pressure as I'm kind of constraining the venous return. Then once I release it to where I'm below the low pressure of the artery, I don't hear it anymore because now I got flow going through the cuff, and I don't have that restrictive force of the cuff. So basically, again, I'm going to pump it up and stop all his blood flow. I'm going to slowly release the pressure that allows blood to go through. I'm going to hear the beats. When I start hearing the beats, that's his systolic pressure. That makes sense. I start hearing the beats when my cuff pressure is the same as his arterial pressure, his high arterial pressure. When I stop hearing the beats, that's his diastolic pressure. And that makes sense because now there's no restriction. The blood can flow right through the cuff because the cuff is no longer slowing the arterial flow. And as a result of that, I don't hear the beating anymore. So that allows me to get a systolic and a diastolic pressure. That's all the blood pressure cuff is doing, right? Okay, so is high blood pressure a problem? Yep, it certainly is. We call it hypertension, by the way. Hyper meaning high, and tension is in reference to pressure. The other possibility would be hypotension. Hypotension is when your blood pressure is low. That's what hypo means in medical terms. So hypotension, low pressure. And both of these can be somewhat problematic. Let's talk first about high pressure. High pressure can be problematic for a few ways, but basically you can imagine why it's problematic. You've got a lot of pressure in your arteries. That is putting strain on the heart, so the heart's getting overworked, trying to push against this pressure, right? Because the heart is pumping, and now it's pumping against a high pressure. It's going to put strain on your blood vessels because your blood vessels are going to take a beating. We've got this pressure going whoom, 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 slamming against the walls of the blood vessels. This is going to do some damage to your arteries. It can damage organs. It can do all kinds of damage to your vascular system overall. So we really pay attention to high blood pressure. Again, normal blood pressure, 80 over 120. Is 90 over 130 okay? That's fine. When you get above 130, we actually start calling that high blood pressure or hypertension. Once you get above 140 to about 180, now we're very concerned. That's called stage 2 hypertension, and that's really problematic. And then once you get over 180 for systolic, so let's say 180 over 110, that's really problematic. That's when you need to make your way to a hospital, right? So we have some leeway, certainly more than we did with, let's say, pH, where we said we have very little leeway and variation, but not a lot of leeway. And chronic high blood pressure of, let's say, 140 as a systolic or 110 as a diastolic is indicating a problem because we know it's putting strain on your heart, we know it's potentially doing damage to some of your organs, and we know it's definitely putting some strain, literally mechanical strain, on your blood vessels that just can't handle that kind of pressure. What causes high blood pressure? Well, if you're very large, medical terms have obesity, that can be a problem. And you can imagine why. The simplest way of understanding this is your body is much larger than it should be. And as a result of that, your heart has to work extremely hard to circulate or perfuse blood throughout your body. If your body gets 50% larger, your heart has to work a lot harder to perfuse blood, to provide the pressure that's necessary to circulate blood throughout your system. Lack of exercise can also be a problem. The heart is dependent on myocardium, on muscle. And so if you don't exercise and don't work that muscle, that's going to be a problem. In addition to that, we know that exercise allows for vascular return, which also helps maintain the health of your circulatory system. So exercise helps. To be honest with you, some of it's just genetics too. If your father or mother had high blood pressure, you're definitely more likely to have high blood pressure, so that can be a problem. And then there's other stressors on your circulatory system and your overall health, like alcohol, other kinds of drugs, stimulants like cocaine or other sorts of things that might work your heart too hard, stress your vasculatory system, or stress organs whose job is to maintain the homeostasis of your vasculatory system. So in all ways, then, high blood pressure can really be a problem. Hypotension, low blood pressure, could also potentially be a problem. But we're going to talk about that a little later because that's related to some acute issues that we will have a whole session on that are broadly termed shock. Shock is when your body can't adequately perfuse your tissue and organs. That's the medical definition of shock. And that could be because you're hypovolemic. Remember, we used that term before, which means you have a low blood volume, maybe because you're dehydrated. Maybe you've been outside in the heat way too long. So not only do you have less fluid, but your blood has gotten thicker. And so now you're working your system way too hard. Maybe you have hypotension because pregnancy is related to hypotension frequently. Maybe you've lost blood. Maybe you have an injury and you're bleeding out. Or maybe you have an organ and it's bleeding and you don't even know it. And you're losing blood. So there are different ways you can have low blood pressure as well. Obviously, some of these are really problematic. So we'll have a whole session where we're going to talk about shock and related to that. But you've probably experienced at least a little hypotension in your life. I think at some point you've experienced what's called orthostatic hypotension. And that is, I don't know, you were laying on the couch watching some movie or something like that, and then you decided you really got to have the Cheez Whiz, and you popped up to move over to the fridge and grab some crackers and Cheez Whiz, and you were like, whoa, and got a little lightheaded, right? What's that lightheadedness? Basically, your blood pressure got lower when you were laying down and your heart didn't need to work as hard to circulate blood. You stood up. It took a little while for your heart to adapt to that new position. And so for a brief moment there, you had inadequate blood flow to your brain and it caused you to be a little dizzy. Orthostatic hypotension. The other way that we can measure perfusion is by using something like this, and there's different versions of these, some larger than others. And what we're measuring then is O2 saturation. Sometimes you'll hear it referred to as O2 sat. This is a pulse oximeter, and you put it on a finger. Andy, give me your finger. Should I put it on Andy's finger? You know what? I'm going to get creative here. I'm going to put it on my own finger because Andy doesn't have a very good pulse. And I turn it on, and what it's doing actually is it's sending light waves through my finger, and what it's measuring is the percentage of my hemoglobin that is saturated. Now, normally my hemoglobin is saturated with oxygen. You should be able to see it there. I think it's 97, 98%, something like that. Yeah, 98%. 98% is good. 98% of my hemoglobin is carrying or fully saturated with oxygen. It's a little bit of a trick to these, by the way, because they're just measuring saturation, not necessarily O2 saturation. So for example, if you were exposed to carbon monoxide, your hemoglobin would be saturated with carbon monoxide. This thing would tell you you've got 98% saturation. You're good to go. No, you're not, because carbon monoxide is not something your organs need. So it's not perfect, but in a hospital setting or a clinical setting, it's a good way to measure how much oxygen is being delivered to your tissue. Notice that it's 98, 99%. That's normal. In fact, anything below about 95% is really problematic. And if you have a 90% saturation, you might think 90%, woohoo, if I get 90% on an exam, I'm happy. No, 90% is bad, because we have to think of it this way. Why is 10% of your hemoglobin not actually carrying oxygen? That's potentially the sign of a very serious problem. So once we get below 90%, then we get into serious concerns. So your body should be able to oxygenate your hemoglobin at a very high rate and provide hemoglobin that is highly oxygenated. Now, it's not measuring how much hemoglobin you've got or how many red blood cells you've got. It's just measuring the percentage of hemoglobin that is saturated with oxygen. There's other things we do too, just simple things like one is capillary refill, where we basically just pinch a finger and the finger turns white briefly, you notice that, and we just make sure that that color comes back pretty quickly. In other words, the capillary bed of the finger, how long does it take to refill with blood? We don't do that much with adults because it varies too much with adults. An older adult, you might squeeze it and have to wait 4 seconds, but it doesn't mean anything except that they've got generally poor perfusion related to some pathologies related to age. But we do it a lot with kids because kids should have pretty good perfusion. So if a child doesn't have a cap refill of less than 2 seconds, that's potentially a red flag. So it's a good way of measuring the adequacy of refill very quickly. We might also look at color, or what we call pallor. Are the fingers white? Are the legs white, etc.? And we might also measure temperature as a way of measuring perfusion. You get the idea. All of these basically just give us a sense of how well the heart and cardiovascular system are functioning, how effectively they're circulating blood throughout the system as quick checks. This class isn't about clinical practices, but I'm hoping that a little bit of discussion of clinical practices now and then will give you a better sense of how the body functions. Okay, I'll see you for the next video.